Okay, go ahead.
Okay, so we welcome to Grand Rounds today for the Department of Psychiatry for the University of Nevada, Reno.
We just can't hear.
Today, we have Dr. Marta Elliott, who is presenting for us. She is a professor. Boy, lots of things going on my computer. She is a professor and chair of the Department of Sociology here at UNR. She's been on the faculty here since 1996. She got her PhD in sociology from Johns Hopkins in 1995 and has been researching social determinants of mental health ever since. Her research is widely published in peer-reviewed journals, and in late 2022, she edited the Research Handbook on Society and Mental Health, which is a compilation of 27 chapters covering topics such as the impacts of police violence, incarceration, and racial, gender identity, and sexual orientation-based discrimination in mental health, approaches to treating mental illness that fall outside mainstream psychiatry, and the social movement to support people while withdrawing from psychotropic medications. For easy access to her scholarly publications, you can visit her website, www.martaelliott.com, and I will put that in the chat as soon as we are done. As soon as I'm done introducing her. So today's presentation represents her evolving interest in the curious comorbidity between bipolar disorder and borderline personality disorder, which she analyzes from a variety of angles with diverse types of data. So please join me in welcoming Dr. Elliott. And I will mute myself, and Dr. Elliott, I will let you go ahead and get started.
They should be able to hear you.
Let's do a test. Can the people on Zoom hear me?
Yes, we can hear you.
Great.
Yep.
Okay.
Yes.
All right, I think we're ready to go now. If you're watching from Zoom, you see Dr. Josh Fitzgerald in the screen. He's helping me get ready to go here, chairman of psychiatry. And you see that I am identified as Marta Lombardero. Sorry about that. This is not my laptop. My name is Marta Elliott. I also have the PhD, but don't mistake me with Dr. Lombardero. Okay, so thank you everyone for coming to this lecture and for the people joining virtually, and for some people who may be watching later. This is being recorded. Before I get started, I wanted to do a poll. This is not a test. This is just a question of how many people had heard this term borderpolar before you saw the title of this talk or heard me say it. Just a show of hands, quite a few of you. Okay, interesting. So borderpolar, as you know, is not in the DSM. It's not a clinical term. I first heard the term when I asked a psychiatrist, what's the difference between bipolar and borderline? I said, oh, borderpolar. So the what? And they said, you know, some people have both. And I said, really? That's curious. And therein was born my interest in this phenomenon. So I'm going to be talking about it from a variety of angles. As see, I am hitting down, but I'm not getting the next slide. That could work.
Forward, just the right arrow.
Okay, so as required, we have a learning objectives today, which is good because that really helped me organize this lecture. It's divided into thirds. The first third is more quantitative. It's about different research methods of estimating comorbidity, if you will, between bipolar and borderline. And we're going to look at how that's done and what kind of results we find when we try to do that. And then in the second third of the talk, I'm going to show you some research that I've done with a colleague, identifying similarities and differences between people who appear to have bipolar, borderline, or both, or neither. And in the middle of that second objective, I'm going to kind of transition from talking about people with bipolar and borderline to hearing from them in their own voices. What are they saying about it outside of the clinical context? And so in that third objective, I'll be talking about some of the concerns that they raised in interviews I've conducted, surveys I've collected, and things I've seen on social media. Okay, so before we get into that first objective, this is a table that I reproduced from a book by Dr. James Phelps that lines up the criteria for borderline personality disorder with bipolar side by side, and it's really quite striking when you see them, because you see that the first 6 things on the list are almost identical, and he's trying to make that point. But I've had psychiatrists look at this and confirm that, well, yes, this is actually accurate. And what is underlined are the things that are different between the two. So when you look by the book at the 2 of them, they overlap considerably. What is different? Well, there's an adjective between unstable and relationships. So type of unstable relationships varies. There's a difference in attachment, the fear of abandonment and chronic emptiness may be unique to borderline. And then the timing of symptoms is different. So people with borderline ostensibly their mood is changing all the time, unpredictably, whereas people with bipolar are having more consistent lengthy periods of depression and mania. Of course, you have rapid cycling or something like that. So it does get a little murky. So you do see a lot of similarities by the book. Okay. This slide is one that I've created after taking the point of view, which I'd like you to try to entertain, because I know I'm talking to an audience of a lot of clinicians or clinicians in training, of what you might do if you went in for a mental health consultation and the professional said to you, well, you got a couple things going on. You've got something called borderline personality disorder and you've got bipolar disorder. Does happen, right? So you would be, I think I should write that down. And what is that? What does that mean? And you're probably a little stunned, and the professional is trying to explain it to you, and you know what it's like to go to the doctor, so you capture as much information as you can. You're educated, you go home, and you get on the internet and try to figure out what is wrong with you. And if you went to some mainstream websites like the NIMH or the Mayo Clinic, and you perused it, you would come up with some very stark differences in the way these 2 disorders are described, even though they share so many common symptoms, right? So you say, I have a personality disorder. Okay, sounds pretty bad. And I also have a brain disorder. Okay, so there's something physiologically wrong with me, and there's something wrong with my personality. Not good so far. This is, I'm trying to take the point of view of what you would imagine if you were reading this. Next question that might come to mind is, why? Why do I have these conditions? So in your research, you might conclude your personality disorder was coming from trauma in your childhood, your home environment. Maybe there's something neurological about the way you can't regulate your emotions. Whereas if you're looking at the borderline, you're going to see that it's believed to be heavily genetic, inherited. You might think, oh yeah, my grandparents were kind of crazy or something like that. You might try to piece it together, that it could be something neurochemical. Maybe it was triggered by a major stressor in your life. Maybe you shouldn't have taken that SSRI. You would read these things. And going on, what kind of treatment? So the recommended treatment would be quite different. So you'd be thinking, I'm in for a lot of treatment. For the borderline, very, very intensive therapy, long-term. For the bipolar, what you will read is, first of all, take your meds. Always take them every day for the rest of your life. Generally what you would read. Phew, okay. And then the prognosis. So depending on what you read for borderline, some parties believe that it can't completely be resolved with this very intensive, expensive, and demanding treatment. Whereas other places you'll read, it's a personality disorder, it's who you are. Whereas with bipolar, the psychiatric orthodoxy is very clear. This is permanent. This is something you will always live with. So that's a lot to take in. Now, why, you might be wondering, as a sociologist talking about this, isn't this something that should stay within the domain of medicine and psychiatry? Well, I'm going to give you several reasons. The first one being, as you probably are aware, there are not clear biomarkers of these conditions. So it is not possible to look at a person under a microscope and say, that's clearly borderline personality disorder, that's clearly bipolar. You don't have those tools. Maybe someday you will, today you do not. So how do you discern who has these disorders? Observation, questions, we'll be looking at that. So in the absence of biomarkers, psychiatrists have been criticized for not using rigorous research methods to develop diagnoses. There is a stereotype, I do not know the extent to which it is true, that these DSM came from a group of people in a boardroom, and some of you have heard this, sitting around saying, I think, borderline is when you have 5 out of 9 of these things, and at least 2 of them make you dysfunctional. I think, and they come to an agreement. And in sociology, we call that the social construction of reality. That makes it very sociological. I'm not saying it's invalid, but this is what makes it sociological. And then secondly, there's the issue of clinician biases, which I'm going to talk a little bit more about. And then third, it's important to sociology because of the impact of the diagnosis on people beyond the treatment, which we hope the diagnosis leads to treatment, it leads to recovery in the best of all circumstances. But there are other unintended consequences. Perhaps there's a misdiagnosis, perhaps the medication that's prescribed is doing more harm than good. They're not perfect, as you know, by any means. Even if the treatment is helping, the person now has a label that is, as you know, stigmatizing and problematic in the larger society. They may internalize that stigma. And worst of all, from my point of view, the thing that I worry about the most as a college professor is that young people particularly will receive these labels and they will research them and they will conclude that they cannot be who they thought they were going to become in their lives. Because the message, as I painted it a few minutes ago, is very powerful and very limiting, unfortunately. So those are some of the reasons why I think it really is a very sociological issue as well. Okay, so getting to objective one, and this I'll go through fairly quickly. I'm going to compare and contrast different ways in which we try to figure out, well, how many people have bipolar, how many people have borderline, how many people have both. So we're going to start by talking about epidemiology surveys and then clinician data. So what is an epidemiology survey? This is usually federally funded, large scale probability sampling based survey that's conducted, designed to represent the entire US population. A lot of the data you read about when they talk about the prevalence of different disorders comes from these kind of surveys. And they do have several strengths. They do represent the adult population of the US. Importantly, they capture people who have not gone to get mental health treatment, right? Because they go out, they recruit people, whether or not they're in treatment, and then they perform a standardized algorithm in this survey to determine whether people meet criteria for a variety of disorders. They don't have to be in treatment to take that survey. But some of the limitations are the data are collected in one setting, we call it cross-section. The person could be having a particularly bad day. They might appear to have borderline personality because what might have happened the day before? Their spouse could have left them. You know, it doesn't really look at life circumstances. It captures the day that they fill out the survey. Also, the survey interviewer is not a clinician. It's not trained in diagnosing. They're trained in interviewing. Third, these algorithms in these surveys don't ask questions about like what happened yesterday. They focus just on what's going on today. And fourth, there's biases like recall bias. These surveys estimate lifetime prevalence of psychiatric disorder. And imagine asking me today at my age, how are you feeling when you were 6 years old? You know? And that is where they come up with some estimates, looking way, way back. So recall bias is a big issue here. And then also just response bias. We tell people what we think they want us to say. So another form of data is clinician data. So what do clinicians put in the chart as the diagnosis for people who come in for treatment? So now we have trained clinicians who are more careful, who are working with somebody, not just in one sitting, but presumably over many months before making a final conclusion of what is an appropriate diagnosis or diagnoses. And also considering what's happening in this person's life. Do they have a physical illness that could be explaining the symptoms and so on? So those are the strengths. But the limits are, it only captures the people who are in treatment, right? Why are some people not in treatment? Lots of reasons. They don't have health insurance. They don't have access to a way to get there. They don't want to be in treatment. They're frightened of psychiatrists, for instance. Or they don't interpret what's going on with them as warranting mental health treatment. And then I mentioned the clinician bias. And let me say a little bit more about biases that can occur. These are things that happen to all of us. We draw hasty conclusions in decision-making. We use cognitive shortcuts. So where this can pop up in making a psychiatric diagnosis is, for example, the availability bias. I've seen a lot of people lately with such and such condition. They come through the doors all the time. So I am prone to seeing that same thing. That's the availability bias. The confirmation bias is going to occur if you are tending to have a hunch about somebody, and then you look for details that confirm or are consistent with that hunch, and you kind of ignore things that aren't consistent with it. The idea of diagnostic momentum is interesting because people have a trail, right? They might see a numerous clinicians, and you might have a new patient come with a long, thick chart that says they have this condition. Do you do a thorough and completely fresh assessment, or do you conclude that, well, I think that, the Dr. Fitzgerald, he's right, I'm sure. So that, not saying anything about you, but that sometimes that can result in a misdiagnosis. And then finally, this idea of the conjunction rule, which is this fallacy that multiple things could be true when it's really something underlying. And I think this is really interesting for Borderpolar because, as I said at the beginning, to me, it seems puzzling that a person could have two quite rare and things wrong with them at the same time. A defective personality and a brain disorder. Maybe there's something underlying that's common, okay? So what is the best both ways of doing this? Well, one is to do a standardized survey, but to do it in a clinical setting where a trained clinician is doing it. And there's something called the SCID-5 here, which is what Mark Zimmerman used. This is a psychiatrist who studies this comorbidity, even published a paper with Borderpolar in the title. It's the only thing I can find out there. But his research is really interesting because what he's done is he's brought people into a clinic who have had prior mental health care, and he asks them, what did your doctor tell you you have? And then they perform the SCID, and then they see, do they meet criteria for what they have been told in the past that they have? And this is very systematic, and I'm showing you the citation just in case you want to double check this. But amazingly, they, of 700 people that they screened in this way, 145 came in saying, I've been told I have bipolar disorder, but only 90 of them did when they did this very careful screening. So Dr. Zimmerman is concluding the opposite of what you usually hear. He's saying that bipolar is being overdiagnosed. underdiagnosed. Okay. You read again and again that it's underdiagnosed, it's mistake, it's people think a person has depression when they really have bipolar 2. This study says something different. So that's his main conclusion. And then he went on and followed up with a second publication of these same people who had come in, thought they had bipolar. According to his research, they don't. So what do they have? Well, here you see that 1 in 4 of them almost met criteria for borderline. So we're seeing a hint here that there's some overlap, there's some difficulty differentiating. Maybe, just maybe, it's more common to diagnose someone with bipolar than borderline. Now, we're to objective 2 already, and this is where I'm going to share some research I've been doing with 2 different types of data to compare people with bipolar, borderline, or both. And I use that loosely. When I say with, I mean they meet the diagnostic criteria. There's no biomarker, so not certain. And I've got 2 sources of data, an epidemiology survey, I was talking about those earlier, and also a self-designed survey. Now, the first study is published with my beloved PhD student, James Ragsdale. We published this paper last year in an epidemiology journal, and this is the abstract. And in case you find this really interesting, you can email me for the full citation if you can't write it down quickly enough because I'm moving right along. I just want you to know I'm just going to show some highlights from this paper. So what this paper is an analysis of a survey called the NSARC-3 that surveyed 36,000 people all total. And it did that standardized algorithm. And it came up with these estimates. 5.9% of this sample. And now remember, this sample is designed through complex probability sampling to represent the adult population of the US. These data were collected 10 years ago. Okay, so we're talking about 2013. 5.9% have borderline personality disorder. Sounds a little high. Okay, you might think, I wonder about that survey. How many have bipolar? 2.4%. That sounds a little more consistent with what we've heard. And then in the middle of the Venn diagram here are the people who have both. It's only 1.5%, it's only 388 people. Doesn't sound like very much, right? But if you extrapolate to the US population, it's 36 million people 10 years ago. Now, even if that's an overestimate, even if that's double, that's a lot of people. Okay, another interesting pattern that we found here was that people who appear to have bipolar, 1 or 2 is what they looked at, more than 4 out of 10 of them also met all the criteria for borderline. Whereas fewer than 1 in 5 people with borderline met the criteria for bipolar. So again, you're seeing this kind of, maybe borderline is more common than bipolar from these data. We went on and we coded the entire sample into 4 mutually exclusive groups. So those with only bipolar, only borderline, both called borderpolars, and neither, which is most people, or 93%. And we looked at some different things. So I'm going to show you just some highlights. These are statistically significant differences. And when you look from left to right, I've got several tables like this. You're going to see a very common pattern. We're starting just with some social indicators here and education, marital status, income, and so on. And you see the people who have neither disorder, the vast majority, are the most advantaged. They're in the optimal position, most likely to have graduated from college, be married, not be divorced, earn relatively high income, have a job, and not be on disability. Move over 1 to bipolar, the numbers jump. Move over to borderline, they go up for the most part even more. And on the far right, in the borderpolar category, I'm sorry, the numbers are going down, depending on which one you're looking at. They're in the worst position. So for college degree, the people with borderpolar are the least likely to have a college degree, the least likely to be married, most likely to be divorced, and so forth. So the pattern of disadvantage is very consistent. Next, we look at adverse childhood experiences, traumas, physical neglect, sexual abuse, you name it, parents fighting in front of the children, having a parent in prison, and we see the same pattern. How often do people report that this happened to them in childhood? Well, it's highest for sure among the group. I can't see my own tables, but that's okay. I know these data pretty well. It's highest for sure among the Borderpolar group. It's also pretty high among the borderline group, not quite as high. But what is also striking is that the incidence of these childhood adverse events is pretty high among people with just bipolar. And if you're the consumer and you're thinking back to that's a brain disorder that's largely genetic, you're like, well, what gives here? Because all these bad things happened in their childhood. So it's interesting to think about the complex causality and how poorly we really understand that. But it hints that trauma in childhood has something to do with the development of bipolar later on. Now, we don't know exactly, these kind of data don't measure genes, they can't. And there's no clear-cut genetic marker for bipolar specifically anyway, but it's just interesting. Also looking at just the past 12 months, you see a similar pattern of stressful life events. What do we mean by stressful life events? The kind of stuff that happens to all of us, because you see the group that have the eating disorder, you know, almost half of them had something happen in the last year, like they started a new job or moved, they broke up with their partner, things that are stressful, but they could get over it. But people in the borderpolar category, they have a lot of stuff going on in the present. And lastly, traumatic events, the kind of thing that is expected to stick with you. It's so awful, you might never fully recover. We're talking about things like being in the heat of military combat, surviving a severe sexual assault, being, you know, held at gunpoint. Again, the same kind of pattern here. So with bipolar, they report a fair amount of that. People with borderline, a little bit more, people with borderline the most. So that's everything I'm going to show you from that NSARC epidemiology data. And just to summarize, so over 4 in 10 people who had bipolar also sort of seem to have borderline. About 1 in 5 people who had borderline also had bipolar. And you see this pattern of exposure to trauma being least among the people who had neither and most among the people who had both. Okay, so then I decided I wanted to ask my own questions, and I'm going to show you just a little bit of that. Designed a survey. James consulted a lot with me on this. In fact, I want to thank James as being the person who's listened to me more than anyone talk about these issues. I designed a survey and I collected data from 100 people with bipolar, 100 with borderline, and 65 with both. And I found them through this website where people do research studies for pay, and there's a screening question about have you been diagnosed with anything. We were able to zero in and target people and interview them. So what did I want to know? I'll just show you a few of the things I asked them. I want to know if they agreed. How about you? You've been told you have bipolar. Do you agree? Only about half of the people in this borderpolar group, which I'm focusing on right now, agreed. But interestingly, they were much more likely to agree with their borderline diagnosis. Now that's really striking because, as you know, borderline, at least among mental health professionals, is more stigmatized than bipolar. I mean, there's a terrible reputation for people with borderline. So you would think, don't you know what people think about that you? Maybe you should identify with the bipolar, right? I mean, I'm being a little glib, but it is interesting to me to see from the patient's point of view that they tend to lean towards the borderline. It makes more sense. Now this 2x2 table shows if you pose the question to all 65 of them, only about half agree with both of these diagnoses. most of them reject at least one of them, right? So they make up their own minds. And then another question I wanted to know is, which diagnosis did you get first? And most commonly, the bipolar came first, followed by borderline. And it was unusual to get both at the same time, but it did happen. Also, I wanted to know, how often did it come from the same doctor? Does that really happen? That situation I set up in the beginning, that someone says, I'm sorry to tell you, you have both of these things. Well, it does. Actually happens quite often. More often than not, though, it comes from different people, and there's a lapse of time that varies quite a bit between the two, just extrapolating from these 65 people that I've interviewed. So lastly, with these data, I want to show you what happens when we compare those other two groups, the people just with bipolar, just with borderline, and with borderpolar. And I'm showing you this because the same pattern I pointed out from the other data set appears with these data I went out and found. So that's always nice when you find that your research is confirming something that a much more expensive and large scale study found, which is that pattern of trauma increasing. But also I asked what I wanted to know, which was, do you internalize stigma? How do you feel about yourself? Internalizing stigma means that you're aware of the stereotypes that exist about people like you, and you accept them. You assume them to be true. This is, of course, a terrible unintended consequence of getting diagnosed. And it's least common for people with bipolar. It's more common for people with borderline. It is most common for people with both. And lastly, we look at just distress. How have you felt over the last 7 days? You know, have you woke up feeling depressed or anxious and those kind of things? And that is worse for the people with both conditions. So now to objective 3, which I think I hope you will find the most fascinating, but also this is intended to be a little unsettling because you don't always hear what people say outside of the clinical setting. And of course, you know, people leave with a lot of questions. They don't fully understand their diagnosis. And so I'm going to share 2 types of data. We'll start just with this open source social media site, Reddit. Probably familiar with it. Anybody can look at this. We have gone on Reddit and we found subreddits designed for people with borderline, with bipolar. There's even a subreddit for people with borderpolar. And we just put in the search terms. And these kind of questions are incredibly common. People are confused. Okay. And I have several posts. We may not have time to go through all of them. No, we do. That clock is stuck on 5 o'clock at that time. Okay, so here's the first one. I like this one because the question they pose is, you know, I can see where they're coming from. They say, I'm starting to doubt if mental illness is even real. You know, they've been told in my teenage years, I was given a lot of medication. I wasn't allowed to know what I had. I was forced to take pills. Now, my doctor has told me I have bipolar, and now my current doctor tells me I have borderline. You know, it's kind of like, what? What's the difference? I'm seriously confused. And think about it. They're posting this on Reddit to a group that has hundreds of thousands of strangers. They're not getting the answer from their doctor. All right. They want to know. They want to know what other people think. This is an interesting one too. Hello, Border Gang. I'd say this is on the Borderpolar subreddit. Yeah, it's a fairly new one. And they are confused. If you look at that second paragraph, it says, I've only been bipolar manic a handful of times. Only takes once, by the way. But for them, a handful of times to get the diagnosis, as you know. And I can't seem to tell I'm manic until it's passed, as my BPD, meaning borderline traits, are incredibly prominent during this time as well. Oh my God, you know, how would you know what is going on? And they want to know. And they say, how do you spot the differences between the two? And you might say, well, does it really matter? You're just really ill. But no, people are curious. They want to understand. They are seeking answers. Now, this post is interesting because it shows that there are people who are frustrated because they are seeking a borderline diagnosis, and there is resistance to it. Okay. So this person says, every time I talk to a therapist or a doctor about my concerns, they are dismissive of me. If you look at the middle, it says, I had no problem getting diagnosed with bipolar 2 right away by 2 different doctors. Everyone readily accepts that, but no one seems to acknowledge borderline. I was even told they don't prescribe medicine for that, even though some people take it. I'm kind of confused. I check every box. It's crippling my relationships, but I can't get out. I have another similar slide. This person, I like this one too. It's very interesting. They said they were diagnosed with bipolar a few months before. Now they're seeing somebody else. They're getting DBT, and it's pointing to borderline. And the person is like, I'm trying to process this. You know, there's been so much instability. I was just getting used to having bipolar, and now I have to come to terms with borderline. Ooh, big oof for the day. Support welcome. I mean, it's funny and it's awful. You know, it's alarming. This is an interesting one because this person is saying they have an eminent psychiatrist, very knowledgeable, very experienced. However, every time they try to talk to their psychiatrist about possibly having borderline, they are shot down. And in fact, the doctor says, you're not manipulative. Did I say I was, right? But the doctor says, you're not manipulative. It also says, one time he even said I was too nice to be borderline, which I found offensive. But he only sees me every 2 months, so fine, doesn't really know me. And meanwhile, other people are telling me I have borderline. And the final paragraph I find incredibly poignant. I'm going to read that out loud. Has anyone ever felt invalidated by their diagnosis or lack thereof? I just wish I knew exactly what's wrong with me so I could get the right treatment. DBT helped, but it's too expensive, you know. I'm just so sick of feeling empty and hating myself. And I think this is the last one from my Reddit examples. This is a person who is in a new clinical setting, and they don't want to bring up borderline with their psychiatrist or their therapist, even though they think it would be very helpful because they know the reputation in that clinic. They know that they're in a place where people with borderline are, quote, thrown to the side as manipulative, attention-seeking, promiscuous, and annoying people. So they're afraid to bring it up, and yet they want help with it. And I do love the final sentence here. As you can see, there's 217,000 people in this group. What do you wonderful people suggest I do? You know, and there's a sense of hopefulness to that, but also of some desperation. Okay, the last source of data I have for you. So remember, I did a little survey. I found 65 people with both diagnosed with both conditions. Only half of them agreed with both of them. So I have been trying to get them to talk to me on Zoom. And so far, 10 of them have talked to me for up an hour or longer. And just a plug, I'm continuing to want to do more interviews with people who have received this dual diagnosis. I'm looking for more, just FYI, that is the direction my research is going. But I'm just going to share with you 4 examples. And the first one is Jessica. So Jessica is a 49-year-old woman. She's single, she doesn't have any kids, and she is currently working for full-time driving a forklift. She disagrees with borderline and agrees with bipolar. Okay, so it was almost 25 years ago that she was diagnosed with borderline. And she says, I remember thinking, yeah, this might fit me, but it might be kind of like astrology. And she said that, I thought, she's smart. Like a self-fulfilling prophecy, you know? And I thought I'd had it for a while, and then I kind of felt I didn't have it. So I don't know, I went through life for a while thinking I had it, and then I realized I'm not that crappy of a person. A little earlier, she was diagnosed with bipolar, and she agrees with that, although it has been almost 30 years since she has had a manic episode. She religiously takes her medication. She believes that if she didn't, she would be in prison because she was really out of control when she was 20 years old. She's taking 5 different meds. You know, what are, you can probably guess. An antipsychotic, she said, a mood stabilizer, a benzo, propranolol, and one more, I can't remember. She's on a lot of meds. How is she feeling? Not very good. She's got chronic depression. She says the meds help with the mania, which she hasn't had in 30 years, but she's not getting any better. She's depressed. And then when I asked her, well, why do you think that you have this? This was very interesting. She said, it had nothing to do with my childhood. I have wonderful parents. They're about to celebrate their 60th wedding anniversary. It's just a chemical imbalance in the brain, I guess, just something I have to live with. So to talk to her is somewhat sobering because she is not a happy person. Her treatment is not helping. Now, Cassandra, though, is the opposite. I almost want to say the bipolar opposite, but she disagrees with the bipolar diagnosis, and she fully embraces the borderline diagnosis. She's 32 years old, really in a good mood during the interview. She's expecting twins. She lives in her sister's house in the basement, and she just works online doing surveys. So she's 32 now. She got the bipolar diagnosis when she was 15, living in a group home for troubled kids. And she kind of feels like they just slapped the label on her because she was a troubled kid. But this interview, I did this about a year ago, I think. And so she was 2 years out from getting diagnosed with borderline. And what had happened was that she went berserk, if you will, because her brother-in-law was refusing to wear a mask during the height of the pandemic before we had vaccines. And she was very upset. And there are children in the home. And she got so upset by his behavior that she just took off, wouldn't come back. And her sister decided that she needed to be put in a psychiatric hospital. But it turned out really well because they said, you have borderline. And she fully embraces it. And she says she now has all the tools that she needs, and she's doing much better. And then I said, well, why do you think that you have developed borderline and not bipolar? And find her quotes. Quotes are really compelling. She said, I have crappy parents, which you can see on the slide. But she went on, she said, my dad was a crackhead and he was incarcerated. My mom was an alcoholic and a druggie, so I had to fight my way out of that mess. And then I said, do you mind having a personality disorder? She's like, no, not at all. She said, I didn't get a chance to develop a personality. I was always focused on survival, making sure I didn't die, that my mom didn't die, that nobody overdosed. I never really got to be a kid and decide for myself. She's like, I genuinely feel with a level head, I can look back on this and say, I did not develop a personality. To me, that doesn't say anything about my mental health. It doesn't say anything about a chemical imbalance. It says I didn't get to develop a personality, and therefore now I have a disorder, complete opposite of the other person. And now the third person is someone who agrees. Yes, I think I do have bipolar and borderline. This is Keisha. She's 34. She's a Black woman. She lives alone. She has no kids. She's a working professional, very successful, works in IT. She's the oldest of 7, so the oldest child stereotype. She's doing great. But when she was 21, she got diagnosed with with bipolar. And she said it made a lot of sense. It helped her understand what was going on in her life. And then when she was 32, she actually spent that whole decade out of treatment, working her way up the ladder in IT, even though she didn't finish college. And during the pandemic, she had to work at home alone and decided this might be a good time to go back and talk to a psychiatrist again, because I'm going kind of crazy alone in my place all the time, doing my IT job. And this time they said, you have bipolar, but you also have borderline. And she's like, okay, I check all the boxes, fine. But she decided not to take her medications. And it had been a year and a half since she'd taken any, because she said, they make you feel dim and not feel anything at all. I do IT for a living. It's fast-paced, high-thinking job. Basically, she said, I can't function on my job if I take my medication. So I was like, how do you manage these two conditions? She said, I've always had a strong desire to not be like the other members of my family. And then when I asked her, well, what do you think? Why do you think you have these conditions? Her story was a lot like Cassandra, the person before. Her childhood was really rough. She says, I grew up in a very rough neighborhood. My mom had me when she was 16. She didn't really know what she was doing. I was moved around from house to house. Even before kindergarten, I stayed with people who were physically abusive. When I was 8 years old, I was sexually molested. I never told anybody. I mean, and it goes on and on. She attempted suicide many times before she turned 21, but she completely turned her life around. And so I said, well, how are you doing? She goes, kind of messy. It's pretty rough. She's not on any meds at all. She's a successful working professional. And I said, how do you do it? She said, I've got good friends. And when I'm having a crisis, I go to them, they talk me off the ledge. She's like, maybe I should probably go back and see a psychiatrist. But she was not in a rush to do that. Okay. And lastly, I have an example of somebody who disagreed with both diagnoses. And this is an interesting case. I hope to interview more people who disagree with both, because in the case of this person, everything he said sort of would lead me to believe that he does have. So, but he adamantly disagrees. And what's interesting about him is that he worked as a social worker for 20 years as a clinician diagnosing people. So he says he knows, and he goes, they got me all wrong. And he told me, this is what mania is, and this is what borderline is. And I am nothing like that. And he said the most derogatory things about both. But then, and he also talked for a long time, far beyond the allotted time. And I just have to say, he said a lot of things that were kind of consistent with what he denied about himself. So all kinds of people emerging from this study. I'm not claiming that these four that I profiled represent those four quadrants I showed you, but I am showing you that to be a person who receives these two diagnoses is not definitive in any way. There's this whole range of experiences and stories behind it. And so I think I'm about done here. I've raised, I hope, more questions than I've answered. I hope I've got you thinking about what this is like from the patient's perspective. And I will stop there and open it up for any comments or questions you might have.
Thank you very much. That was awesome. We've had quite a few talks on just bipolar disorder in general, borderline personality disorder in general, from Dr. Garcia Ryder. So this was just a really great way to conceptualize something that we all see. So thank you so much for joining us. I'm going to open it up for questions. I don't see any questions in the chat immediately. Diane has posted the link to the survey and the CME code as well. So please go ahead and fill that out if you need CMEs. And I'll just open it up for questions. If there are questions in the Grand Rounds room in the Learning Studio, could you repeat the question so that we can all hear it?
So I guess one of the questions that I was thinking about was when looking at the trauma and the components from childhood and the component for both borderline personality disorder and bipolar disorder, there's a high likelihood that someone that was a caregiver in the home carried one of those diagnoses. Have you seen anything or kind of looked at anything on that realm, or how do you feel like that plays a role in this as well?
Okay, so the question is that people who meet these criteria experience trauma in childhood, and perhaps their caretaker, their parents or their guardian also had the diagnosis. So that could imply that it's genetic, that they were raised by somebody with the diagnosis, and it could also imply that the symptoms of having the condition, permeated the home environment. I think both are possible. I think it's very difficult to separate. Scientifically, we really can't very easily, except these twin studies with all of their flaws, separate genetics from the environment. I can say a lot of people talk about their parents having mental health problems too, or whoever they were raised with, and that it runs in their family. Yes, Emma.
So taking a step back and kind of, looking at this from a sociology perspective, I'm really curious how you hope to, I don't know if influence is the right word, but how you hope to kind of put this different perspective on diagnosing and how people receive the diagnoses.
I want to reach an audience of people, 3 audiences really. You are one of them. Clinicians who do the diagnosing to, raise awareness to the extent that you're curious and interested, to raise awareness of this particular comorbidity and how it impacts the people who hear that they have it. And just to get people thinking more about some of the issues with diagnoses and their limits and their implications. And I also want to reach people who have the dual diagnosis so that they feel, if you don't mind using a cliche, seen and validated, not just on social media, but to have somebody with a platform like I have, because I'm a professor and I publish, speaking and amplifying their voices. And then I think there are a lot of family members who want to learn more about it from the point of view, from different point of views, not just from a medical perspective. And there's other academics that are interested in this, philosophers, psychologists, so on. So all those audiences I'm trying to reach, just to kind of be a little provocative and get people thinking.
Thank you. And kind of like a follow-up question to that is, with your interviews of the dual diagnoses, is there anything that's come up that, you're for clinicians to be like, if they do this, or if they kind of consider this may have changed something? I guess, like, from a training perspective, my question is there any common theme that you've seen so far that we as clinicians should consider?
Well, I think you saw it in those Reddit posts, something that to really pay attention to. Why not entertain the borderline diagnosis? What stereotypes are you carrying that might discourage you from entertaining that diagnosis? If you look at, the stereotypes are horrible, the treatment is difficult, there's no FDA approved medication. What do you have in your toolkit? You actually have to refer to someone else. So refer to someone else, right? There is a standard of care that can be very effective for it. That would be one thing. Yes.
I feel like we always entertain the idea of borderline as that's something we talk about, but we always also have a conversation of, if there's no absolute change to what you would do in treatment, we don't necessarily you don't want to label a person with that, because other clinicians who would see the medical record may become more dismissive and all that. But from your presentation, it almost seems like having that diagnosis an explanation to why my life is the way it is comes with some sort of relief to people. I guess I don't know. That's what I'm trying to ask, but this is interesting point about. I guess, like, from your perspective, from the work you've done, having the diagnosis, the benefits would outweigh the negatives of carrying the label.
I actually am not sure about that. As I said, this raises more questions than it answers. I think the label is really problematic. I mean, I can understand why you would say, I don't want to put that on someone's chart, because it is a fact that it's going to conjure up stereotypes from others. So clearly one actionable item is to work on reducing the stereotypes. Now, stereotypes often have a kernel of truth. There are people who meet criteria who are difficult. How do you overcome this reality? How do you overcome compassion fatigue and really truly understand how somebody came to be how they are? I think that is where hearing their stories with a little distance, reading about them, knowing the full story of what they lived through can be helpful. But I still find the borderline label problematic myself. I know that in the UK, they changed the official name to emotion dysregulation disorder, I think. Does that sound right? I don't know if that is really helping, because I see in UK discourse, they still just call it borderline anyway. So not changing the terminology doesn't necessarily help. But really, the idea of a personality disorder is something that we need to continue to interrogate, because it does imply that it's a permanent character defect. And if that is what it is believed to be, then why would you want to deal with somebody with a permanent character defect? So maybe the terminology needs quite radical reimagining.
I have a question, but I have a comment on that first.
Okay.
I think it really does matter on the diagnosis, because the treatments and the evidence-based treatments are drastically different. So not putting it on somebody's chart, if we're putting borderline personality disorder on somebody's chart and we have good evidence-based practitioners, everybody is going to be on board with this person needing DBT, mentalization therapy, other evidence-proven therapies, where we know medications may help a little with impulsivity, but don't help a ton with underlying symptoms.
Can I pause on that? And so the data does show, if you give a person correctly a borderline personality disorder and you do nothing else, there is a reduction of symptoms, because there is identification of what is causing it, even if you don't treat it. And so that's why we've talked about giving the correct diagnosis of why that is really important, because that can be treatment even in the face of no other things being done for that person.
I have one more thing, sorry.
But also, question given so many answers.
So the other thing to consider is there's the risk of the stigma that is, of course, something to consider, but there's also the risk of not having an accurate diagnosis, leading to physicians down the line prescribing medications that are not appropriate because they don't have the full picture that maybe you had at the time that you thought of that diagnosis, and so they're more likely to incorrectly be diagnosed with something that then leads to medications that have their own risks.
It's almost like when you get a patient who only has 10 psych meds, it's like quasi-diagnostic.
Yeah, I don't know if people on Zoom can hear the conversation in the room, but I see somebody is raising their hand. Alice.
That's me. I'm raising my hand. I can't see everybody else talking, so I thought I would just raise my hand. I wonder, I think on Zoom we can hear the conversation as well, and it's a really good conversation. Thank you, Doctors Garcia Ryder and Saracen Hall. I wonder from a sociological perspective, how do you feel about changing the name of a problem, a stigmatized thing? So just saying, never mind, it's not borderline personality disorder anymore, it's EDD now. To me, my foundation is in history. My educational foundation is in history. And I feel like as a population, our history is very important. It's important that we keep our history. So how do you feel about it from the perspective of a sociologist, of just abruptly changing the name of a stigmatized diagnosis?
I think I'm interested in it because, as I said, we abandoned a lot of labels that are really problematic, not just in the area of psychiatry, but, you know, labels that are racist, we set aside. You can think of it as akin to that, because even, you know, we have a history of racism, we have a history of discriminating against people with personality disorder. To me, that is a potential thing to consider. When there's problems with the history, then maybe there needs to be a revision to the conceptualization and labeling of the person's situation.
I'm curious as to if, on the history question, if you're going to see a change in these demographics over time from the standpoint of some of our historical training trends and diagnosis have changed. And so when I came through training, adult training primarily, I know this a lot in the adult world, I was very much taught, and my child training has changed this, that we don't diagnose borderline personality disorders in minors. That personality disorders are diagnosed in adults. I think that the child psychiatry world views this differently, but we know that bipolar disorder historically, a juvenile bipolar disorder, we see onset in adolescence. And I'm wondering with this change to the research on severe mood dysregulation in kids and the change to disruptive mood dysregulation disorder being implemented in the DSM-5 in 2013, if we're going to see a trend of more borderline diagnoses earlier and less bipolar diagnoses, because we have the severe mood dysregulation disorder that maps onto adult depression and anxiety, which is not bipolar disorder. I'm just wondering if we think there's going to be a change because our diagnosis of bipolar has drastically changed in pediatrics and adolescents over the last 10 to 15 years.
Going up or down?
Down.
Okay, because it really spiked with that book, The Bipolar Child, which was like about 25 years ago. It's like all of a sudden all children had bipolar. So now that's turned around. Yeah, well, you can tell me, I don't know, I'm not a child psychiatrist.
I would echo that because I feel like, I mean, I get kids all the time who are just screaming borderline at me, but they're 12, 13, 14, and they're diagnosed with bipolar or DMDD. And I think, you know, even for a child who doesn't have the brain development of a 25 or 30-year-old, there's still a lot of validation in just describing this diagnosis and saying, does this sound like you? And just like Emma was saying, if you identify it and you diagnose it, even if you don't treat it, symptoms do regress because the foundation of it has a lot to do with chronic invalidation. So I find myself torn between wanting to stick a label on a 12-year-old and not wanting to stick a label on a 12-year-old that's very stigmatizing, but also wanting to validate that 12-year-old's experience. So I find that a challenging balance.
I mean, it really is a dilemma. What you need to do is to spend the time with this child, helping them validate them. But to have to tell them you have this terribly stigmatizing label in order to be able to do that is a dilemma. Like Mohan and GR unmuted. Is there another question?
That's this room.
Oh, well, that's us. Okay.
But I would like to thank you, and this is a fantastic presentation on a fascinating diagnostic conundrum that I think troubles the mental health field on a regular basis.
I think we have a question on the Zoom. We've got Kathleen Carroll with her hand raised.
Hi, thank you. Thanks for the presentation. I have a question regarding the SCID statistics and if there's corrections for people's poor recall of hypomanic or manic episodes in not diagnosing bipolar. That's one question. And then the other, would it be your experience with major depressive disorder mixed?
Okay, your first question was those SCIDs, do they correct for poor recall? Well, I mean, I think we'd have to ask Dr. Zimmerman. It's not addressed in his article, and I didn't do that study. And how do you adjust for poor recall, right? I agree with you that a manic episode is something that a lot of people will not remember. So that's a problem. So those data are imperfect. Something's happened on my screen. Can you repeat the second question?
Sure, if you're familiar with or have worked with major depressive disorder mixed as a diagnosis, it's where a person doesn't meet the full criteria for hypomania, mania, but they do have something along the lines of some type of bipolar without the full criteria, and with major depressive episodes.
No, not really. Haven't heard that one. I mean, I know there's many different types of bipolar and each new DSM has new types. But I haven't interviewed anybody who told me that they had that. So I don't really have anything to say about it. Anybody else? Remember, I'm a sociologist. But I should write that down. I mean, did you have a thought about it?
Well, I do see a lot of people that have had abreactions to SSRIs, and they haven't had a full hypomanic or manic episode. And just as a psychiatric provider, I generally will err on the caution on the side of treating them for bipolar disorder versus borderline, just with the risk of suicide with a person with both bipolar and borderline, or a person with bipolar 2 disorder and their depressive episodes.
I find it interesting when people tell me that they took Prozac or they took Zoloft and like everything went crazy. I always kind of take that with a grain of salt because those meds can be very activating at first. We know chemically they stir things up before they settle down. So I try to tell people about that. Like, you may feel really anxious for the first few days, and then if that doesn't go away, then we talk about it. But I take that kind of with a grain of salt because of again, the recall. People have poor recall, and especially if they're feeling depressed, their recall is even worse. If they're anxious about starting a new medication, that's going to affect their recall. So I try to really spend the time to do a good informed consent about those kinds of things, because you do get these weird stories where I took Prozac and it made me totally crazy. And it's like, yeah, well, what else was going on? Okay, you did meth that weekend too, but you didn't remember that part. So I really try not to sort of do guesswork in that particular category.
So I think the evidence maps pretty clearly onto behavioral activation as a side effect to SSRIs and antidepressants being kind of subclinical symptoms of hypomania. So we see a little bit increased energy, maybe agitation, some mild impulsivity, but they don't meet criteria for hypomania. That typically, in most of the people, and these are people they're seeing who are reporting immediate side effects, does not map onto bipolar disorder, but actual hypomanic or clinical manic episodes do map onto bipolar. So this is the hard part, where if we start having these type of episodes with multiple antidepressants, I think your data builds towards bipolar. But on a single antidepressant, if it's not meeting full criteria for hypomania or mania, I think the evidence says it doesn't map towards bipolar.
Yeah, and just to hear someone say I err on the side of bipolar kind of makes me shiver, because of what I showed you in the beginning, you know, that the person who is told they have bipolar is being told that they have a permanent condition. And you don't hear that many psychiatrists entertaining the idea that maybe it's temporary, maybe it will resolve. I hear more concern about if we don't continue treating this person, they might have a relapse, which of course is a valid concern. But I talked to too many people like Jessica who've been depressed for 30 years and are over medicated and are afraid to take a chance just to see what is actually going on, underneath all that.
Just a comment, just respectfully, and that's where provider bias comes in. I've seen probably the other end of the spectrum, the person that's ended up in jail following an SSRI, or the person who has had a severe suicide attempt, that type of thing in my practice. And so I respectfully appreciate where you're coming from also.
Yeah. So there's just all kinds of people. What bothers me is a one size fits all rule, because not all people are going to be in that situation, but then there are those that you have to protect, absolutely. And how do you know the difference?
I'm curious, when you were doing these interviews with people, did you find any interview style or questions that particularly resonated with people that could be clinical pearls that we could take into our own practices? Because it is difficult to say, even just the term personality disorder, because that carries a lot of weight. So it's always uncomfortable to bring up that topic. And in order to destigmatize it, we, the clinicians, have to be more comfortable. So I wonder if you found any really effective or impactful ways of saying things.
Well, I don't know that I'm approaching it from the same point of view as you would be, since I'm just asking kind of as a non-clinician. But one thing I think is a great idea is to ask people what they think they have. I mean, ask them, what is your idea of, if you can take that time, of your problem? What name would you put on it? And what do you think caused it? And partly because I think their perspective is valid, but I also think that can be helpful in the therapeutic alliance. So that's what I would encourage the most, is getting their voice. But I don't have a different language to use, except that I imagine that focusing on the experiences that led to the traits of borderline personality disorder is going to be a lot more helpful than talking about having a personality disorder.
What other questions are there on Zoom or in the learning studio? Okay, we can wrap up. This was totally awesome. Thank you, Dr. Elliott. If we can unmute on Zoom, if we would like, and do some applause now in the learning studio, please. Let's just show our appreciation. Thank you so much for coming. This has been just wonderful. And thank you for the slides. They're actually really helpful. So that will.
Thank you.
Thank you very much.
Thank you. Are you still willing to move it over to, we don't have a clock or you?
So are we stopping recording now?
Yes.
Remind me that to record.
Hold on just a second. Let me pause it.